Thank you so much indeed. Thank you, Dr. Ashraf Abu Ali. It's a great honor and a great pleasure for me to be with you today. Always the most active, the most delightful team of enthusiastic scientists and so forth. Dr. Hassan Ali, I think you might be the Japanese guy that Professor Abdelmajid Ramzi alluded to. He's saying you let the genie out of. I think that's what you're doing. And all your team and Dr. Ashraf Abu Ali, Dr. Sharif Gafar, and all the team are really helping a great deal in all the tremendous effort that you have been really doing with us. I don't know if you're. I'm sharing the screen, and yes, we're good to go.
Yes.
Fantastic. Slideshow. Let me get that. Yes. Okay.
Yes.
So your symposium is a really complete symposium. Going to Dr. Abu Bakr Nashar talking about the adolescents, going to Professor Abdelmajid Ramzi talking about the management of the extreme end hyperstimulation syndrome, covering the diagnosis, covering the classifications, and so forth. So initially, I had it all kind of summarized here, but I don't think I need the first 3/4 of it whatsoever. I want to tell you that there are two groups of women. This is what Howard Jacobs, my former boss 35 years ago, used to say, the obese patients with the central and metabolic effects and the young and slim patients. And we're all aware that those young and slim women are the ones that give us hyperstimulation, even worse than the overweight one. Their metabolic features are different, and although I fully agree with you that the metabolic features are not used for diagnosis, but they are different. Like here you'd have high LH to FSH, the others you have more of high insulin resistance. I would not cover those. You've covered them beautifully, the Rotterdam criteria, the NIH, and all that, the cutaneous manifestations, as you've all alluded to, the central obesity and its compounding. The mechanism of insulin resistance, maybe at one other lecture we can cover that. And honestly, I recommend to Professor Hassan Ali, my dear friend, and all the team, Dr. Ashraf Abu Ali, Dr. Sharif Gafar, we can publish a little booklet, all of us together on those issues here. So let me go really from the end. And you've covered everything from obesity to hirsutism to amenorrhea. They talk about the groups of the combined oral contraception was very useful, with alluding to which ones were neutral, which ones were androgenic, and which ones were anti-androgenic. I think is very useful. This is the list that we have been through today from Professor Robert Norman's talk. Clomiphene, letrozole, and others to HMG and FSH to laparoscopic ovarian drilling, first as a treatment of the PCOS and to induce ovulation, and then also as a method to prevent hyperstimulation. Weight loss, no question, it is very efficient. And again, I'm running through those as if I'm summarizing the conference today. Been used 60, 70 years at this point in time. Most of the pregnancies happen in the first few cycles, so there is no point in staying forever on Clomid. It does not help at all. The endometrium, we all are aware that in normal cycle, you have this beautiful trilaminar with the Clomid. You do not get these nice endometrium. The effect is possible through the blood supply that is between the myometrium and the endometrium. That is where the anti-estrogenic effect is exposed. I will not, again, metformin, I'll say two words, that many of the prospective randomized trials that have gained famous, for example, this one in the New England 2007, showing that metformin alone did have no effect, and metformin when added to almost also had no effect. So Clomid was the winner here. And again, another study from the Netherlands showing you the same. But when you look at all the meta-analysis, as you have all showed today, this is another study in the British Medical Journal from Holland, showing you exactly the same, that there was no additional benefit from adding metformin. But when you look at all the meta-analysis, here is a meta-analysis on 17 studies that you have mentioned today, and definitely showing you that the addition of metformin was useful at induction of ovulation, as well as getting pregnancy. And again, another one where metformin was added to FSH, showing you that it is beneficial. In clinical practice, I do use metformin. I use it more for the obese than the non-obese, and it could be helpful, as you've just mentioned a few minutes ago, in the non-obese because of lowering of the insulin levels. Aromatase inhibitors, you've had that covered beautifully in another seminar, so I will not go into that much. Laparoscopic ovarian drilling, this is one of my surgeries, doing laparoscopic ovarian drilling using robotic surgery. So I always joke and say that this is how to, instead of using Clomid for $5, you do a robotic surgery for $25,000. This is the summary of this study. Again, I want to mention one probably very important message. You've heard Dr. Abmegid Ramzi, my dearest friend, and he's telling you that high dose so-and-so causes extreme over-response and hyperstimulation, and the patients themselves are over-responding. And then we move on to the very low dose, 37.5, and so on, say it doesn't work. Well, the real issue for all of us, the challenge, is what's in between. What's in between? And this could be, Dr. Hassan Ali, and I'm just throwing this idea, a topic for another day, another talk. By all the real clinicians, that you use 300, you get a very high response. You use 225, you still get a high response. You use 150, you don't respond at all. So forget about the 37 and the 50 international units today. That could be a talk for another day. But let's focus on the in-between. The in-between is the challenge, that if you lower those just enough, you get no, and if you increase it a little bit, you get still extensive response. I think that today, and I'll come to that in a minute, all these factors here are used by all of us. I mean, and forget about is AMH better or antral follicle count. Of course, anybody that is going through IVF has to have an ultrasound and has to have an AMH. I mean, it would be a kind of bizarre to do a treatment that is so extensive and and don't do those. So we do all that. We take the age, of course. We take the previous response into consideration. A patient says she's been admitted twice before. You have to be careful. However, what does the word careful mean? I mean, what does it mean 150 instead of 200? Does it mean 150 instead of 225? And you can, there is plenty of interesting literature, though not as conclusive literature in this group of patients. Again, this was AMH, where I'm not going to cover all today. Let me go into the part that I really want to focus with you today. I think that today, and I have changed radically, and we, many years ago, we were part of the team that popularized the GnRH agonist in London in the 80s. I mean, at that time, when all IVF started, we were in central London, and the commonest protocol that we have used from 84 till 86, 87 was a combination of two things: clomiphene citrate 100 milligram from day 2 to day 6, HMG day 4 from at 150 units a day. This was this protocol. And then one of the ESHRE meetings, a group from Belgium suggested that the agonist might play a role. And then my mentor and boss, Dr. Howard Jacob, Professor Howard Jacobs, one of the legendary pioneers of polycystic ovaries, suggested that we give it a try. And Richard Fleming from Glasgow did some work, and we started using it extensively. And we did, a series of studies, really extensive studies by Dr. Charles Kingsland and others. And all those suggested, actually in a prospective randomized clinical trial, using different protocols of agonist on first-time IVF. And there was like one of the largest of them was 800 randomized study on first-time IVF, showed that this was a great thing. So agonist stayed with us for a decade. So it was very difficult for me to change from agonist and so forth. The real change I change is not because, is really for two reasons. As all of you concluded correctly today, that the antagonist decreases the OHSS. And if you use the antagonist and use GnRH agonist to trigger, and you freeze all, you almost have 0%. And honestly, I use it exclusively. So all our patients now, almost 99%, go through an antagonist protocol, go through an agonist trigger, and also go through a freeze all. And then some other things that are controversial. So let me tell you, your studies from Cairo, Dr. Lanani and others showed that definitely the incidence of OHSS was lower. The very first meta-analysis showed that the antagonist was lower than the agonist, and then they became equal. I don't think there is any studies that I'm aware of that showing the antagonists are significantly better. So I'm not using it because it's better, but I'm using it because, exactly as Peter Hamadan and others said, it allows the triggering with the GnRH agonist and the freeze all embryos, and then you control things better. So we let the patient rest for a month and then come back and have either estrogen or Lupron, then estrogen, and have I will go into extreme IVF detail, which this is my real talk. So the others was really an overview, but this is the next 10 slides are my talk today. The details of which agonist, how much HCG, what luteal phase, how much agonist trigger, and so on. So the agonist trigger, as Dr. Abmegid said, that it replaces the FSH, it pushes the FSH and the LH that has been stored in the pituitary. So the antagonist prevented you from releasing that FSH, LH, and then the agonist comes and makes you release it. How much agonist you use? We've changed I have changed over the last 10 years. So at the beginning, we used to use 2 milligrams, 36 hours. And then for a period of maybe 5 to 10 years, I have used 2 milligrams, 36 hours, and another 2 milligrams, 24 hours prior to egg pickup. And the reason for that is that there was a thought that if there was, that those patients who did poorly because their LH was lower the next day and their progesterone was lower. So if you give an LH trigger, which is another bolus of GnRH, overcome that. And then now we use most of the time one shot of 4 milligrams of Lupron. Lupron, because it's the one that's commonly used in the US, as you're all aware. There are at least 6 or 7 GnRH agonists globally, and having worked in the different places in both in Europe and the US, there is definitely, you have to be familiar with 2 or 3 of them so that you're comfortable with them. So again, we use Lupron, but you can use any of the agonists that you like and that you use. The Lupron dose we use is 4 milligram. It comes kind of prepared, so it's a 0.2 milligram per. Two international units per 0.2 milliliter. So when we use the 4, we use about 0.8 ml of the agonist as well. If you do that and you freeze the embryos, it would be rare to have hyperstimulation. Could you have hyperstimulation? Yes, you could, but it would be truly rare to have hyperstimulation. And as we all get older, we try not to deal with them at all if we can. Unless you use. So again, the dose of the agonist that's been used has varied from 1 milligram to 4 milligram. I'm unaware of higher than 4 milligram being used routinely. We currently use the whole 4 milligram. A higher agonist dose would be expected to displace the antagonist more effectively, because if you bring the patient, and you don't need to bring the patient, but if you do, and check her LH and HC and the progesterone the next day, and it's very low, it was thought that this is why some of those patients failed. So many people used 2 milligrams and 2 milligrams. I'll show you data to the opposite in 2 minutes. So at this point, we're using 4 milligram once a day. Could you use it in hypothalamic amenorrhea? The answer is no. So what is the price for the agonist? The price for the agonist is that if you're still going for fresh transfer, you will have a very poor luteal phase with a very marked, very poor luteal phase. This is a study from Bruce Shapiro from Las Vegas 10 years ago, where he showed that the agonist trigger was associated with basically a poor luteal phase. And Bruce Shapiro is is one of the biggest advocates for freeze-all in all the cycles, not just in specific. But at least there are 4 or 5 indications for freeze-all, including, of course, over-response, but many others, including also using the GnRH trigger for any other reason, including hyperprogesterone, like most of us do. Pure progesterone is above 1.5, then you would consider also a freeze-all. This from the GCM 15 years ago or so, showing you the difference in luteal phase between in normal responders between a group of women who were given HCG and another group of women who were given GnRH, and it shows you quite clearly that the progesterone levels are significantly suppressed in the luteal phase in women given GnRH agonists as opposed to women giving HCG in this study very clearly. Going again from Cairo, this was a meta-analysis, and I think was followed by at least 2 more since then. But this was 8 randomized controlled trial. 3 of those were were also using donor eggs, not done in Cairo, but these were done internationally. And when they looked at the agonist trigger versus the HCG trigger, in the agonist trigger, there was 0 in 437 cases. In the HCG, there were 28 in over 400 cases, giving you a 7%. So where is the catch here? The catch here is the last line, is that the live birth was reduced. So if you do use Lupron trigger, and again, this was not his own study, so he was not trying to push either, the hyperstimulation was significantly reduced from 7% to 0%, which is remarkable, but the live birth rate was also reduced by 56%. The odds ratio was 0.44, and the confidence intervals are quite remarkably, there is 0.29 to 0.68. What do I mean confidence intervals like that? That you really, this is not something that is borderline, that there is definitely a price to be paid. So again, so far I've shown you evidence that in many of the randomized controlled trials, there has been a significant reduction in OHSS. There has been also a significant reduction in the pregnancy rate. So what do we do about the pregnancy rate? Botros analyzed and said, well, why is the pregnancy rate low? So here it is. He looked at the luteal function, again, another JCEM, Journal of Clinical Endocrinology and Metabolism, study showing you the LH, FSH, progesterone, and estrogen in women giving different agonists, including Lupron, which is leuprolide acetate, triptorelin, and so forth, and comparing with HCG. And showing, again, a remarkable difference, and then showing you also what happens when you start supplementing with progesterone in the form of IM injection, 50 milligrams. 6 years ago, in 2015, almost 6 years, 5 years ago, they looked specifically, what about PCOS patients, our topic for today, versus non-PCOS patients, and what do you do if you use an agonist trigger? So they looked at PCOS patients, and there was 40 of them on the right side, and the non-PCOS patients, and there was 74 on the left side. And they looked at the number of follicles. The number of follicles was higher in the PCOS, but both of them were remarkably high, 35 and 30. When they looked at the number of eggs, the range was higher with the PCOS, but the mean was the same, was about 16. We looked at how percentage maturity was 80% versus 74, and the fertilization rate was closer. So what is important about that? When they looked about what are the odds of things going wrong, in the PCOS patient, 3 women had no eggs. Like they had all of, so here I showed you they had up to 35, mean 35 follicles. But here, 3 of them from the 35 follicles got low eggs. There was always the hypothesis that the women that did not get eggs after triggering is because the trigger didn't work. Why do I mean by didn't work? It did not release the LH. So if you bring them the next day and check the LH, that LH should be 15, 20 or more milli-internationals per ml. So they thought, well, must be that the LH was not released, and hence the luteinization in the granulosa cells was not complete, and the progesterone levels were low. But all the 3 patients in this particular publication that was there had actually an LH 12 hours later, meaning that the bolus of Lupron or GnRH was given, say, 8 p.m. At 8 a.m., they had the blood test, and it showed an LH of more than 15. The progesterone also was good, was above 3. Of the women who LH, all the 3 that I told you failed were basically did not have those normal, basically had perfectly normal criteria. When they said, okay, what do we do now? We don't have eggs. They give them HCG to give them 10,000 units, and it did work, and they got eggs, but the patient has severe hyperstimulation and was hospitalized for that as well. And we can talk later about the dose of HCG and the chance of hyperstimulation and so on, but that is not the main point. Another study was not a paper, but was an abstract, was a poster in the ASRM in about 2007 that said that there is a certain high rate of what we call empty follicle syndrome. Basically, that you give the Lupron and then you look at it at the follicles after aspiration and find granulosa cells, but do not find mature eggs. So they stopped after. They did one side, they did half the case, and they stopped, and then they did the other half 7 hours later after, and they got a mean of 8 eggs. So this is the second study, the 2007. They abandoned actually was the only significant thing about this was this was a huge study showing 119 empty follicle syndrome, which we all are aware of. It's very frustrating. 12,000 IVF cycles. Aspiration was abandoned after one side was done. Second aspiration was done 6 hours later, and they got a mean of 8 eggs as well. So this, again, we haven't solved the problem. The problem is, yes, we got low hyperstimulation, but low pregnancy rate as well. So people said, well, what if we give a little bit of HCG, not much HCG? About 10 years ago, maybe 12 years ago, I did a supplement to human reproduction together with 2 other authors, actually at the request of Professor Edwards before he died, to look at basically HCG, OHSS, the different doses and so forth, and different protocols. And I'll tell you 2 just interesting things, and then with your speakers today, the discussions on those could be unlimited. But I'll tell you two I think, very interesting points to me. The first point is the straightforward one. One of my co-authors on that was Dr. Luciano Nardo from the UK, and he looked at the dose of HCG. What would happen if you lower the dose of HCG? Would you abolish OHSS or not? And actually, the first one that ever came up with this idea was Dr. Hossam Abdallah from London. In 1987, he published Infertility Rates. So this study was done between 84 and 87. He used the 3 doses of HCG. He used 2,000, 5,000, and 10,000. And he showed that if you drop the dose of HCG from 10,000 to 2,000, you would get much less OHSS. But if you also drop the dose from 10,000 to 2,000, you will get much fewer eggs and much lower pregnancy rate. I mean, this was 33 years ago. I couldn't remember the pregnancy rate, but the pregnancy rate was like a third or a quarter using 2,000 compounds. So he was the first to try that. There's been about 10 papers looking at that in the past 30 years. And then the summary is that if you use 5,000 instead of 10,000, you already does not abolish the OHSS at all. So the concept that you use 5, because it's traditional that, for example, in Europe to use 5 instead of 10 in general, and also in specifically in patients of high responders because of the the normal thinking that if the HCG is part of the problem, then lowering the dose would do. It really did not abolish that. So this was the conclusion of Luciano Nardo in our in our edition. This was actually an interesting addition to human reproduction. The second is something I could never really forget in my life. In the old days, and this is again before Google and internet and so on, we had this going back to the late 80s. So in 88, we had a case of severe hyperstimulation. It was not our patient; was actually another friend's patient from London, and she ended up with a stroke, and we published it, and I published it in Human Reproduction. His name is not on that paper, but again, there was very little literature and data and so forth. So there was a library called the World Society of Medicine. I take it underground, go to the World Society of Medicine, get permission to have access to the old thing, because I didn't know what to do with, I mean, it was the patient. The patient stayed 21 days in the intensive care. And well, it was shocking. She had the typical huge ovaries and they were bleeding, and we operated by, as my boss at the time, his name is Inias Fisher. Dr. Fisher said, the message from that is not to operate on them and not to call him. So I think he was absolutely right, because we couldn't get out of the case. I mein, but we managed to finish the case. So during the search for those articles, we find the original classification of OHSS. So Dr. Abmegid Ramzi kindly mentioned that we did a classification, me and Dr. Abu Ghar, in 1999. Ours was the fifth in a series of classifications. The first one was 1967. So when I pulled it, forget about the classification and all this waste of time, I read with the greatest interest the cases themselves that they published. So this group was from 1977, was from Israel, before actually there was Israel at the time, as we know it today. They had a table of the cases. So it wasn't just, mild is this and moderate is more and severe is more than more and so on. They said what was done in the treatment. So a couple of those patients actually died. So the first classification involved 7 patients, 2 died. And one had an amputation. I mean, heroic stories. And like Dr. Amagid said, arterial thrombosis, etc. The most interesting thing, and you can still go, this was published in the American Journal, in the Gray Journal in 1967, was they gave the details of the treatment. Nobody at the time used, FSH or HMG and then reached a certain size and then gave HCG. So there was no ultrasound and there was no hormone. So they would do what they call the Insular score. They check how much mucus from the cervix, how big are the ovaries on bimanual exam, and adjust the dose. So they gave a bunch of HMG, then stopped, then give HCG, then give HMG again, and so forth. In many of those patients, in many of those 7 patients, and you can go and check this for yourselves, the amount of HCG that was given was around 28 to 30,000 international units. And again, nobody knew that it was 10 or 5. I mean, all these are recent ideas, not recent. I mean, there is no evidence that 10, who came up with 10? I mean, I tell you, some of the most eminent people in London in the 80s used bigger doses than that all the time, not for any individual patient. And they always felt that the cumulus was better, etc., etc. So what I'm telling you is that the HCG is one of the least investigated areas in our field. So anyway, because the Lupron gave very low pregnancy rates, so they said, well, let's give a spoon of sugar. So they used 1,500 units of HCG. And indeed, there was a significant improvement. And a group from New York, Dr. Benadiva and his team, they said that if your E2 on the day of HCG is less than 4,000 and you give the agonist alone with estrogen and progesterone, even at very high dose, you will get very low pregnancy rate. So you have to add about 1,000 units of HCG. Personally, I freeze all. I do not do fresh transfer on those patients. Again, from Peter Hamaidan, another prospective randomized controlled trial, he had 300 patients. They were randomized to agonist plus 1500 the HCG or 10,000 of HCG. And when he looked at the pregnancy rate, it was the same. So it became obvious that if you're going to do a fresh transfer, then you use a 2 milligram of Lupron or more if you wish, plus 15,000. That HCG was done at the time of the retrieval, not at the time of the classic HCG to mature the egg for resumption of meiosis and so forth. So the HCG was given later to help the luteal phase. They used daily vaginal quinone and then oral estrase 2 milligrams twice a day as well. And they still had only one patient who developed severe OHSS in this group of patients, 1 out of 71. Again, it is meaningless to say, oh, this is 1.5% or so on. Bruce Shapiro, again from Las Vegas, this was a retrospective. This was not a prospective, and he did many retrospective randomized trials on the elective freeze-all. But here, he used 3 protocols. He gives, in some patients, he looked at the patient that he gave the agonist on, meaning giving GnRH agonist without giving any HCG, and they had about less than 100 patients. Another group, they did dual trigger, meaning they give both an agonist plus the HCG. And then in the last group, he gave the agonist, but he gave tremendous amounts of estrogen and progesterone. He gave the HCG depending on the weight. So he gave from 5 to 15 units per pound. Basically, that averages to 1,500 units. So just for simplicity, when we say dual trigger here, we mean agonist plus 1,500 units of HCG. And they looked at the 3 pregnancy rates, the pregnancy rate in the 3 groups, The pregnancy rate, if you used agonist alone, was 25%. When you used the dual, meaning agonist plus 1,500 units of HCG, it was almost 60%. And if you used agonist and intensive luteal phase support, it's 50%. The loss is the opposite, suggesting that it is the inability of the luteal phase endometrium to sustain the pregnancy. And hence they concluded that the use of Lupron alone and fresh transfer is associated with the lowest pregnancy rate in this setting was 25%. The highest loss rate in this setting was 60%. So if you're going to use Lupron, you either add 1,500 units of HCG or do extensive luteal phase support. In the dual group, meaning that the ones you give 1,500 HCG plus the Lupron, approximately 1 in 200 had hyperstimulation. The LH trigger, the LH to trigger, simply it does not work because it would need a significant amount of recombinant LH, which is extremely costly. And actually, I would like to conclude here that there is a huge difference between the 2 practices that exist in the world, which is giving a very, very low dose, as Dr. Abmeghi said, is frustrating and doesn't work. And this is 37.5 or 50 or 75, and then 2 weeks, and then you increase and so on. And then giving a very high dose, which is a classic, frankly, American practice, if you want to say. So getting some of those young women with high response and giving them 300. What about the in-between? And the in-between is the most challenging. The in-between, I mean those from 100 to 250 units. So they're not taking 300 and they're not taking 50 and 75 and so forth. And what are the increments that are useful in those group of patients? So I'd suggest that future research should focus on those. Of course, there are studies, and there are studies looking at FSH alone and FSH and in an HMG form and in a form in which HCG is used beside the FSH and all that stuff. But again, it's a great area because at the end of the day, the biggest determinant for OHSS, as Dr. Abmeghi said, is over response. So your idea would be to undercut. Yes, we did not give them massive dose. We didn't give them 450 in somebody who's a very high AMH, but we still give them 225. And is 225 high? And then you go to 150 and they don't respond at all. And I had many of those people that do not respond to 150 and over respond to 225. And I had many patients. Majority of the PCOS that we see do not have the huge number of follicles that we are all talking about. But a few patients that I had had really many follicles being 80, 90, and that kind of stuff. So I give them, 100, 125, 150, they don't respond. So I go a little bit more, and they grow all 80 follicles. And at the end, the only thing I can do was to do an ovarian drilling, not to make them pregnant, to dampen the response to the next IVF cycle, not as a way of pregnancy. Again, choice has to be careful, and this would be my message here, that I think for PCOS patients in 2020, an antagonist protocol with a GnRH agonist is the way forward, is the way now. We use freeze all, but again, it is a blessing to have a good vitrification program. So if you have an excellent vitrification program, you sleep well on that. It allows you other things, but this is not today's talk. Whether you want to do genetics, PGT, you don't. I mean, this is another day, another time. But it allows you to also have time to think about all those. And for many of those patients, one embryo transfer is good. Not that I'm an advocate of one embryo across the board, period. No, but I'm an advocate that if you do have a single normal blastocyst euploid, you do have definitely a very, very decent pregnancy rate with that. I thank you so much, and thank you for putting up with the stories at midnight in Cairo. And you have a wonderful evening. Thank you.
Peter, the difficult patients that you spoke about, patients who have 150 and do not respond and have 225 and they hyper respond. How do you suggest that we characterize those patients? What do you think? Who are they?
Well, in my, I didn't have many of those, but in the group, they were overweight. They were classic polycystic ovary. They had clinical hyperandrogenism in a big group. Some of my worst hyperstimulations ever were in the slimmest patients. So we had the two, but the ones like that had, I remember two in particular in my entire life. One in London, very slim, very little. We gave her those days there was basically 275s. And one of the fellow ahead of me by 1 year did her egg retrieval in the morning. We got 64 eggs. That was one. And then another one I had about 10, 15 years ago. Every time I go just a little bit above 150, I have 80 follicles. 80? Yeah, 80 follicles. Honest to God, 80 follicles, all equivalent. The classic honeycombing that you see that we all put, showing 20 on each side, forget about 20, 80 follicles, 45 and 45, and so on. And then I sweat it, and then, if it depends on my mood, if I'm in courageous mood, I try to modify. Not, I quit and start again. And then at the end, I said, this is not going to work. One day I'll be traveling, there'll be something, and the disaster will strike. So I actually decided to do drilling, and I was able to stimulate her. I don't think she got pregnant, but I was, and the other one was 64 eggs, did not get pregnant too. Like we put them at the time, 2 at a time, and she never got pregnant. Many of the others, as we were all very familiar, have bad hyperstimulation, and they get pregnant. And it stays weeks,
In terms of concerns about the neonatal outcome of vitrification, how do you think the future of this GnRH agonist trigger with antagonists going on and freeze all?
Yeah, that's a very interesting point, and I'll tell you in all honesty, I was very interested in that. Actually, I think at the same time you were in the US, I was in the UK at the time, and we did the first, we did the first 1,000 babies born. Actually, at the time was the first 1,000 babies born in the world, period. Not in our center. Those babies were conceived between 1980 to 1988. And of course, the numbers, I still remember them because these are the few studies that stayed. All the rest are washed down now. But we looked at the numbers, and the abnormality rate, the major anomalies rate, which was classified different ways depending on England and Wales versus England, Scotland versus Great Britain, was 3.5%. And we had the control group, again from England and Wales versus those, was 2.5%, and it was not different. So this was the first huge, I mean, this was the first 1,000 babies in the world, period, and the largest, and there was no increase. And then three, four reports came in the Lancet from Australia suggesting transposition of the vessels and spina bifida, and then to others they said, those guys are making terrible babies and so forth. And then several studies showing the ICSI having very, very high anomalies and so forth. Then I lost interest. I mean, 20 years passed and I lost interest in my own data and in what happening. And I was I think I was in Egypt listening, or in the Middle East for sure, listening to the group from Denmark and Sweden. And they presented all the data showing there is absolutely no difference in the stuff. So sometimes it's good to be out of the game for like 10 years, don't look at any data on there. I just, at the end, was tired to follow that, it's terrible thing, it's good thing, and so forth. But I think that, as I'm sure you're following with me, now there is almost a huge study, but coming from China and so on every year or two, showing some changes, like some studies showing bigger babies, some studies showing bigger placenta, some studies showing some preeclampsia and so forth. And whether this is really an issue of placenta, we always believed from the beginning there was an issue of placenta with IVF, not an issue with the baby itself. So I honestly don't know, to be just simply honest with you, I don't know the answer to.